Hello everyone. We've now been working on type 3 restrictive disease, and sometimes in the setting of restrictive mitral valve disease, we have patients that have a very small left ventricle, or they have hypertrophic cardiomyopathy or asymmetric septal hypertrophy that can result in gradients in the left ventricular outflow tract. Traditionally, these are done through a sternotomy with a combined transaortic septal myectomy and mitral valve repair or replacement. So in this episode, we're going to perform a transmitral septal myectomy and a robotic mitral valve replacement. Let's take a look. Now, what do we do with an 82-year-old frail woman with a predicted risk of mortality of 5%, with atrial fibrillation, previous pacemaker, LVOT obstruction due to her significant MAC, resulting in mitral regurgitation, and significant septal hypertrophy? This is not something that's easily feasible with transcatheter therapies. And the patient had atrial fibrillation, so we proceeded to apply her to robotic technology to avoid the liabilities of a sternotomy in this frail woman. You can see this demonstrates how we can avoid tissue gaps with a robotic technique, as we've demonstrated previously in previous videos. Again, inferior box lesion after the epicardial coronary sinus lesion, followed by superior box lesion to avoid Bachman's bundle. And then the mitral line. And then approaching the right atrial lesions in the presence of a pacemaker. So this is very important because we have to avoid jailing the atrial lead. So first the tricuspid line, and then the placement of the IVC line. Again, we don't snare to avoid any issues there. I want to make sure you get a good lesion that not jails the lead. And then we can see the implant of the atrial lead is actually in the mid right atrial body. So this actually works out well. We can avoid that. And then the IVC line. This does demonstrate the care it takes to make sure we don't make your incision near the atrial lead or your ablation that actually jails the lead. It makes it non-functional. And completion with closing of the left atrial appendage. So now let's approach the mitral valve. So this is a heavy calcified posterior MAC. The anterior leaflet is small and restricted, and we have septal hypertrophy with LVOT obstruction. In this case, obviously, we're not going to preserve the anterior leaflet cord groups due to the severe posterior leaflet disease and MAC, since we want to avoid systolic anterior motion or outflow tract obstruction at the final proceeding. I think we can avoid the MAC, but we're going to do a septal myectomy. So this is the debulking of this septum using sharp dissection, transmitral. And you can see you can get easily down into the ventricle below the papillary muscle base to get a good intraventricular resection, to then relieve this outflow tract obstruction. And without resecting the MAC, we're going to put slightly larger needles to encircle and fold the anterior leaflet tissue as its same, nearly an autoplegic equivalent. And then we'll be able to use these to get around the MAC, which was fairly straightforward in this case. And in this small, rather frail woman, we were able to put a 27 bioprosthesis, again, rotated approximately 20 degrees counterclockwise to avoid LVOT issues with the posts, and completion of the mitral valve replacement, biatrial Cox-Maze procedure, and myectomy in this woman who now has no residual LVOT obstruction. So now we've seen how to do a transmitral septal myectomy and mitral valve replacement. In our next episode, please join us because I'm excited to share with you a new technique of how we manage tricuspid insufficiency due to the restriction of an implanted pacer lead.